medicine, specifically on the medications. The next one is going to be 7B, and it's going to be on the surgical side of it, the bariatric surgery. We're going to talk about the pros and cons for using weight loss medications, their mechanism of action, and some of their side effects. I remember from previous presentations that all diets through research have shown that you get an initial weight loss. And then at the best of times, over 2 years, unless lifestyle changes occur, that the weight is returned and then most of the time is overshot. So all of these diets, all the macronutrients diets show the similar failure. So Mediterranean, paleo, all of those. So medications come into play because they are able to help reduce the set point when all the diet and lifestyle changes fail. So let's go and review set point. Set point is where the weight increases over time, and it's where the adipose tissue stores accumulate, larger and larger adipose stores from years of exposure from these different lifestyle choices, I guess I should say. And so as the set point gets much higher, it's very difficult to reduce that weight. So here's an example showing weight loss at age 17, around 120 pounds, and then at age 60, climbing up slowly through the years to a weight of 150. And actually, this is myself, if I'll be honest. So these are my food choices, sleep deprivation, type of work I did, the stress involved with the work, the yo-yo dieting, intermittently, fasting, trying to lose weight, calorically restricting, and then weight gain inducing medications. Those are things like Benadryl, sleep aids. Some of those will cause increasing weight gain. Now, before we go on to exactly what the medications are, I want to talk about the treatment. This is a stepwise approach. This is directed by the Obesity Medicine Association, who recommends that the initial step are those self-directed lifestyle changes. And then from that, going on to professionally directed lifestyle, where you're working with counselors, nutritionists, exercise, physical therapists, helping you find the right exercise program, for instance. And then from the next step comes medications. And the medications specifically are only for those people with a body mass index over 30, or they can be given to people with a body mass index of over 27 if they have comorbidities that would respond to weight loss, and those would include hypertension and diabetes. And there's some arthritis, some other things that will be considered comorbidities. And then from that is weight loss surgery. So all along the way, you have to start from the bottom, you have to go up with all of them. So if you go on to medications, you cannot discount self-directed lifestyle or continuing to work with professionals. Medical scenario. Your 45-year-old sister has been trying to lose weight for the past 5 years. She has a BMI of 35. She has borderline hypertension. She's done everything to improve her lifestyle. She's seen a nutritionist, worked with Weight Watchers for the last year. Still, her blood pressure is high and she has only lost a few pounds. She's getting very frustrated. So what is your advice? Should she jump on to gastric bypass surgery, see an obesity specialist to prescribe weight loss medications, continue with changes, and continue with counseling? And going back to that treatment that of an additive approach, the answer is see an obesity specialist, medical medicine specialist, and prescribe weight loss medications that are safe. And in her case, you'd want to make sure it's medication that would not interfere with her borderline hypertension. Medications, along with these lifestyle changes, is intended to drop that set point. So that's the point at which a person is not feeling hungry all the time. They're comfortable, they're not hangry, they're not fatigued from low metabolism. So this is what medications are intended to do, is drop that set point. Taking a guess right now, what is a patient's greatest fear about taking weight loss medications? Is it the cost or the complications? And certainly cost is not so much a barrier, because most of these patients have gone through extensive Nutrisystem, Weight Watchers. I mean, all of those cost a lot of money. So the cost is not so much the issue, as people are worried about complications or side effects from medications. Talking about side effects, the side effects are massive if the morbid obesity is allowed to go on for long periods of time. So medical complications of obesity include all of these things: pulmonary disease, fatty liver disease that can actually go into cancer eventually when it goes through the cirrhosis stages. They can have abnormal menses, developing arthritis, skin disorders, gout. Cancers are directly associated with morbid obesity. Heart disease, diabetes, hypertension, stroke, cataracts, all of those things are associated with the medical complications of obesity. So this is going into what medications are used and what their mechanism of action. Now, currently, there is no medication to stop ghrelin from being produced by the stomach. There is only the surgical approach. So the current weight loss medications target the appetite, or how comfortable you feel after eating, and the metabolism, which is your inner fire. And the metabolism is the greatest caloric use within your body, as opposed to exercise or digestion. So it's targeting increasing the metabolism and decreasing the appetite. So specifically, the medications that raise metabolism are things like phentermine, diethylpropion, and phendimetrazine. These are the generic names. They come in the trade names as well. So these are just some examples. Years and years ago, amphetamines were actually used. These medications are not amphetamines, although you notice phentermine has the same ending as amphetamines, but they do have the potential to slightly raise the blood pressure and the heart rate. So by increasing the metabolism, what they do is, the mechanism is they stimulate the sympathetic nervous system to a smaller degree than your own hormones that are produced, or hormones, and they're also considered neurotransmitters, epinephrine and norepinephrine. And these chemicals are released by the hypothalamus in response to like an outside threat. So your sympathetic nervous system gets activated. It innervates the adrenal medulla, and epi and norepi. And whenever people have a severe fright or significant fright or significant threat, there is a drop in appetite. So increase in heart rate, slight increase in blood pressure, and the result is a decreased appetite. So these medications are less, I guess, strong is a good word, that like epi and norepi, but the result is a decrease in appetite and an increase in the sympathetic nervous system, an increase in the metabolism. The side effect of these are, of course, like if you've watched a really scary movie right before you go to bed, is insomnia. People get much higher blood pressures if they already have hypertension, and it can make people kind of irritable. So you need to make sure that these medications are given early in the morning. So again, this is going over the pathways of stress. Just to remind you, there are two types of stress. The acute stress, these are the outside threats. And that's characterized by this saber-toothed tiger chasing the caveman. Acute stress initiates hypothalamus, and then into the adrenal medulla, and epi and norepi are released, and food intake is decreased. That's opposed to chronic stress. Still have activation of the hypothalamus, but a different drug or a different chemical is being released, and that's cortisol. So chronic stress actually increases cortisol and increases insulin resistance and increases appetite. So these drugs do not target chronic stress. They target more of this acute stressor side that decreases the appetite. All right, there's other medications for people that maybe have borderline hypertension. These medications treat only the appetite side of it. And those examples of medications, there's several more, and I'll give you an entire list at the end of this, and you can access that through a PDF. The examples include Lireglutid and Metformin are also considered medications that target satiety. Metformin is very mild agent. Lireglutid is much more effective, but I'll go into that in a moment. So before we go into the satiety, the pathway of these medications, remember the hunger satiety pathway, where the stomach is empty, it's releasing ghrelin. On the other side are these hormones that are being released. So pancreas releases insulin. Insulin would not be a great drug because you would drop someone's blood sugar dangerously. Adipose is releasing leptin. People with significant morbid obesity have leptin resistance in their hypothalamus. So, and leptin is extremely expensive to produce at this time. So leptin is not a choice. So it leaves us with these intestinal hormones, GLP-1 and PYY. Okay, so based on what I just said, what hormone could you safely mimic to improve satiety? Would it be insulin, ghrelin, or the gut hormones? So right, it's the gut hormones. Those are the ones you want to mimic. And again, insulin would drop blood sugar levels very dangerously low. That would be a dangerous medication to use. Although there are some studies now using nasal insulin, I just was reading about nasal spray. But they would have to be, patients would have to have their blood sugar monitored closely. And of course, GLP-1 is the mimicker, also called an analog or a lookalike. So going over naturally produced GLP-1, also called glucagon-like peptide 1. Within 10 minutes of eating, your gut starts getting stimulated and it starts releasing GLP-1. It is a great chemical. It helps the pancreas release just the right amount of insulin based on your blood levels, blood sugar levels. It promotes satiety and provides organ protection. The problem with the naturally produced GLP-1 is it's very short acting. So trying to give exactly GLP-1 is difficult. So they need to develop an analog that's longer acting. GLP-1 has some great bonus features. It is very protective for all of these organs. With bones, for instance, it increases bone density, protects the liver. Patients that are on these types of medications have a hepatic protection, improves brain, improves actually taste. It also protects the muscles, the adipose tissue from releasing the dangerous cytokines. And it's also been shown to improve your immune system and reduces the risk for cancer and diseases. And I'll show you the studies in a minute. Okay, so the challenge that GLP-1 is very short acting. So they're producing medications that either increase your own GLP-1 release from your intestines or analogs that are similar and longer acting chemicals. So these are, this is the medication. It's called Saxenda, that's the trade name. The generic is called Lireglutid. So it's an analog, it's very similar to GLP-1. It's a once-a-day dosing. Unfortunately, it's only by injection. But some of the ways it works is acting on the satiety pathway and slowing down gastric emptying. People really do take offense at this injection. However, it's the same size needle as insulin. So if patients are diabetic, this is really not a bad option, and it's extremely effective with very, very few side effects, if any. The other one I talked about, mentioned previously, was Metformin. It is a much milder form of a GLP-1 analog. It was first derived from the French lilac plant in the 50s, I think, 1950s. It was used to treat type 2 diabetes. So as it becomes manufactured, it came out in pill form, started being used in the 60s to treat type 2 diabetes. And it does promote GLP-1 release, so it improves the pancreatic release of insulin to just the right amount. Now, taking Metformin or Lireglutid, they're perfect for someone with prediabetes or diabetes. And these medications will not drop the blood sugar level. That's a really important concept. They are not insulin, but they improve insulin sensitivity. They improve receptor sensitivity. So it reduces the blood sugar levels. But patients will not get hypoglycemic on these medications. So this is the research about metformin. It's gotten the interest of longevity studies, longevity researchers. They noticed that the animals that were on these medications, on metformin, or the trade name is metformin, but the generic would be glucophage. They noticed that the animals lived longer in all forms, life forms, increased the extension of life, and it decreased the risk of having cancer in animals and in humans, all of these studies. So they do have the proof of stimulating people's longevity genes. So patients on metformin have a decreased rate of cancer. So it has a lot of advantages. As you can see, it changes the microbiome. So the interesting thing is one of the side effects that is noted on the bottle is that there might be initial diarrhea and cramping. What that is a change of the microbiome. And that's why when the metformin is continued taking it, the diarrhea goes away because the GI tract is now switching over to the better diverse microbiome with more Bacteroidetes. It improves brain, liver, gut, circulation, all of those, and it decreases inflammation. So even if it doesn't have a massive amount of weight loss, it does have all of these protective effects. This is a study, and I bring it up now because we're talking about COVID so much. They noticed that women with obesity who came into the hospital with COVID-19, they looked at two groups, one group on metformin and one group that were not taking metformin. And they noticed that the patients that were on metformin 60 days before they came into the hospital had a 20% lower risk of death from COVID-19. And the particular author had mentioned his conclusion was that women with obesity or type 2 diabetes should all be on metformin. Okay, let's go on. Those are the drugs. Let's go on to some other questions about other options that are non-prescription. So what about if you just replaced all your sugar with artificial sweeteners? Would that help you prevent weight? Is that a good idea or a bad idea? Answer, this is a really bad idea. These are the solutions that are not recommended for weight loss: smoking and artificial sweeteners. The research on artificial sweeteners showed that people who were on artificial sweetened beverages actually increased their risk for type 2 diabetes and increased weight gain. And I'll show you why. So artificial sweeteners tend to increase the weight, they increase metabolic syndrome, they increase the risk for type 2 diabetes and heart disease. The pathophysiology is that these artificial sweeteners kill the Bacteroidetes in the gut, and they feed the bad Firmicutes, and the net result is weight gain. So an alteration of the microbiome by the artificial sweeteners. Oh, what about smoking? Smoking, well, look at the nicotine effects. It does increase the metabolism, there's no doubt about that, and it is an appetite suppressant. So let's look at the medical scenario. Your 34-year-old sister smokes a pack of cigarettes a day. She wants to lose a few pounds and is afraid that if she quits smoking, she will gain weight. What are her chances of gaining weight when she stops smoking? Is she going to gain 10 pounds in a year, or is she not going to gain weight? The answer is yeah. Once you stop smoking, you will gain weight. This is a study showing in the majority of cases, the increase in weight, and it ends up being about 10 pounds of average weight gain over a year. Okay, so let's look at the downside of staying on smoking. Nicotine has an anti-androgenic effect, and I did a little bit of extra artwork here to show that nicotine, because it's blocking the estrogen, increases facial hair. It causes the fine wrinkles. It's associated with heart disease. And despite the lower BMI associated with smoking, instead of having the adipose deposition all over the body, it's deposited more in the visceral area. So you have more central obesity, which is risky for inflammatory diseases. The other problem with smoking is smoking during pregnancy increases the risk that a child is going to be obese. Also, it increase with the other factors that increase a child's risk for obesity is a mother having diabetes. And interesting how you wouldn't think there's any possible way, but if the father is obese, either mother or father is obese, it increases a child's risk for obesity. So what a mother does may impact her child's risk for obesity. So summary, we went through the medications, the value of GLP-1 besides satiety as organ protection and glucose stability, blood sugar levels being nice and even, how artificial sweeteners are microbiome disruptors causing weight gain in the wrong, that will turn around, cause weight gain. And then in terms of weight gain, nicotine makes the weight gain right around the middle, where you definitely don't want it, where visceral fat is more metabolically active, meaning that inflammatory diseases are much higher in people with the apple versus the pear shape. This is a list of all the medications for anybody who's interested. These are the medications. First is listed the trade name and then the generic form. The mechanism of action, how it may decrease hunger, and some of the side effects, of course. A couple more pages. These are the ones that decrease appetite without affecting metabolism. So these would be the option for people who were hypertensive. There's one more list, some of the others. And any questions, please leave comments, subscribe to the channel.